Now, as we know, and we've already talked about, the shoulder joint does move through three planes of motion. It is a ball and socket joint. It is one of the most movable joints in the body, which makes it the least stable. Hence, we tend to see quite a few injuries at this particular joint because of the amount of mobility that's available there. The shoulder joint can produce motion in three separate planes: flexion extension in the sagittal plane, AB and adduction in the frontal plane. And then in the transverse or horizontal plane, we see internal or medial rotation, external or lateral rotation, as well as horizontal AD and abduction. In reviewing or getting ready to think about the shoulder joint, it's important to understand the bones that are important attachments for the muscles that are going to control the motion of the humerus. The scapula is one of those bones, and the scapula has a depression called a glenoid fossa that's going to articulate with the head of the humerus. The glenoid labrum, as we've already discussed a little bit, is a piece of cartilage that sits within the glenoid fossa, and it has a number of different jobs. We'll talk about that some more. Essentially, it creates a vacuum or a suction to hold the head of the humerus in place. It also is important for mechanical advantage for the muscles that need to be kept tight and remove any kind of slack. The subscapular fossa is on the back of the scapula, so the part that articulates with the rib cage. The infraspinatus fossa is the depression underneath the spine of the scapula, and the supraspinatus fossa is the depression above the spine of the scapula. You have the axillary border and then the acromion process, which are all important attachments for muscles that are going to control the shoulder joint. In looking at the humerus, it's a fairly straightforward bone. It's got a long shaft. It's got a neck, which is going to be primarily cancellous bone, and then the head of the humerus that's going to articulate with the glenoid fossa. Now, it is important to remember that as we look at the humerus in relation to shoulder joint movement, we really just need to focus on the most proximal end, which is why we are looking at the head, the neck, the shaft, and then two tubercles or two parts of the bone that stick out significantly and provide attachment for muscles: the greater tubercle and the lesser tubercle. So you've heard about the rotator cuff. You hear about people who have rotator cuff tears. The rotator cuff really actually is four separate muscles that help the deltoid muscle. Um, So it's important to talk about the stability of the shoulder and then again revisit that labrum. The labrum is important, as I mentioned, because it increases the depth of the glenoid fossa, and because of that, it helps to improve the mechanical advantage of the supraspinatus as well as primarily the middle deltoid. In a moment, we're going to talk about the three deltoid muscles. They tend to work together to produce abduction, but the prime mover, um, the primary role of the middle deltoid is shoulder abduction. It is probably the strongest shoulder abductor. Around the shoulder is a capsule. We've talked about that capsule. And so within that capsule, we have this vacuum created against the labrum that helps hold it nice and tight in the socket. There are many ligaments in and around the shoulder that are important to think about, are going to help keep those shoulder injuries from occurring, but regardless, they still do potentially happen. I am not going to require that you know the specific ligaments at the shoulder, but it is important to understand that there are many ligaments there with their primary role to hold that head of the humerus in nice and tightly. The rotator cuff provides stability to the shoulder, provides a nice um, tight fit of the head of the humerus, and keeps it well balanced with internal rotation, external rotation, and then that pull that keeps it up and inside of that glenoid fossa. As I mentioned before, we're going to see some muscles that are going to be affected significantly by stroke, and that supraspinatus is one. We're going to talk about it in just a second, but the coracobrachialis is also a muscle that assists with shoulder stability. Now, as we take a look at the muscles of the humerus, and here's where you're really going to want to probably make some study cards for each of these. Looking at the deltoid has three parts. It has an anterior, a middle, and a posterior deltoid. The anterior deltoid is primarily responsible for flexion. That's the forward movement of the humerus. It has several other jobs. It helps with shoulder abduction. It helps with medial or internal rotation, and it helps with horizontal adduction. But when we think about the prime mover of shoulder flexion, we think about the anterior deltoid. The middle deltoid has a sole responsibility, that is shoulder abduction. The posterior deltoid then, primary role is for extension. It does also assist with abduction. So when all three muscles, all three parts of the deltoid muscle pull simultaneously, we get abduction. But when just the posterior portion pulls, we end up with extension. It is also a lateral rotator and helps with horizontal abduction. Okay, for the supraspinatus, its prime role is shoulder abduction. Again, just a reminder that it is important for heading or holding the head of the humerus in the glenoid fossa. The pectoralis major is a very strong adductor. It is also a medial rotator. Now we see the pectoralis major muscle get very strong and very tight in the case of a stroke. Quite often it develops contracture. And what we have is an arm that's pulled in very tightly to the side and rotated in an inward position. One of the biggest problems for people who have stroke is the inability to have external rotation or lateral rotation because this massive muscle is so strong pulling inward. It also assists with horizontal adduction. The lats, the latissimus dorsi, primary role is for extension. It is also an adductor, and it is also an internal or medial rotator. The teres major is really the little helper of the lats. Now, the lats can produce hyperextension as well as just extension, whereas the teres major sort of stops and is not able to help with the job of hyperextension. So it is an extension muscle of the shoulder joint. It's also an adductor and a medial rotator. And it will help you to look at the pictures of the books to kind of figure out how the lines of pull produce these different types of actions. Now, the teres minor and the infraspinatus are both have the same job. They work together to produce lateral rotation or external rotation. They also assist with horizontal abduction, but their primary role is lateral rotation. The subscapularis, as I mentioned previously, is part of the rotator cuff, and it produces medial rotation. The coracobrachialis is a stabilizer of the shoulder. It is not a prime mover. Its only function is to stabilize and help the supraspinatus. It keeps the head of the humerus, again, up into the glenoid fossa. Now, we've talked previously about arthrokinematic motions, and we know and understand that at the joint surface, three different types of motion or movement can occur between the surfaces of the joint. The surfaces can spin or rotate, they can glide or slide, and then they can roll. Now, in the glenohumeral joint, we see all three of those arthrokinematic motions occur, and I will go over those in class. But essentially, as we abduct our humerus out to the side with the thumb facing the ceiling, what we're going to talk about in class is that the rolling motion of the head of the humerus is going to roll down in the joint. It's going to glide slightly inferiorly, and the head of the humerus is going to get the most range of motion when it spins or rotates laterally.